Welcome to the Advances in Research and Innovation stream of SNOMED CT Expo 2023. My name is Victor Medina, and I'm a surgical terminologist in SNOMED International. I will be moderating today's session. All questions will be answered at the conclusion of the presentation. Online attendees, please use the Q&A button to type your questions to the presenter. On-site attendees, please use the microphone provided in the room. I'm now pleased to introduce Jerrod Anzalone from University of Nebraska Medical Center, who will be presenting implementing interoperable social determinants of health data for social equity in healthcare. Jerrod, please go ahead.
Great. Yeah, thank you for having me, and thanks everyone for being here late on a Friday. I have an ambitious outline here and a lot of slides, so I'm going to move quickly at a high level, talking about the need for interoperable social determinants of health standards, existing efforts to standardize SDOH data, our solution to enhance this, which is adding observables at the community level, a quick primer on how we've deployed those in the US at a very granular geographical level, and then use cases from our Nebraska lexicon, SNOMED CT extension. So this is not a new concept, even though it's getting a lot of priority right now. Social determinants of health have been known as a major contributor to health for a very long time. On the right-hand side, this is a graphic from the WHO that was provisioned more than 30 years ago, still very prescient today. You'll see on the right-hand side, healthcare makes up a minority of those contributors. On the left, we see a similar overarching theme about our relative contributions to health, where health behaviors contribute about 30% of our health outcomes, clinical care 20%, social and economic factors a massive 40%, and then the physical environment 10%. So put a little bit more succinctly, the Healthy People 2030 framework and this quote sum it up nicely: your zip code is a better predictor of your health than your genetic code. So why is this important to the standards community? This data represents the same struggles that we have with clinical data, and that we need comprehensive data capture. It gives a better peek into our patients and our population. It facilitates consistent data sharing, reduces ambiguity, allows us to create patient-level SDOH-based, evidence-based interventions, and it enhances health equity. And I think those align well with SNOMED CT's core goals. So the existing efforts to standardize SDOH data are pretty immense. The big name in this field in the US and elsewhere is the Gravity Project. It was born from the Social Interventions Research and Evaluation Network in 2019. And I'm not going to go into great detail into the work that they've done. They presented here last year, and the recording is on YouTube. I'd recommend you to watch it. But they have done a lot of work identifying gaps in coverage and identifying specific terms that are out there that relate to SDOH data, focusing on assessments, goal management, referral management, and patient engagement. Beyond that, the US government has prioritized this. We heard yesterday from the national coordinator, the US CDI Coordinator for Interoperability Standards have added SDOH elements with every new release. Through release 4, it continues to prioritize it. The VA has a module on SDOH factors, and then last year the Biden administration announced the Sync for Social Needs Coalition, which focuses on uniting this across vendors, including the VA, Cerner, Epic, and others. And then I don't want to ignore international efforts. That wasn't the focus of this presentation, but there have been significant international efforts to standardize SDOH data as well. And the individual research community, since it's a research-focused talk, the Odyssey community, the N3C community, and the CoreNet community have all made relative contributions to standardizing SDOH data, or at least identifying needs. So with that in mind, in 2023, where does SNOMED CT measure up? They have nearly 350,000 concepts. Approximately 5,000 of those relate to SDOH data. So here we see health behaviors, which again is 30% of the relative contributions to health. Those are things such as smoking, alcohol consumption, and diet, and they are generally very well captured in SNOMED CT's concepts. These are recorded from a clinical perspective, so they focus on the individual patient rather than looking at, community or population trends. So it's very well captured in the terminology, not well captured in the records. Clinical care. This is where SNOMED CT shines. This is what it's set up for. This data is captured well. Again, this is not community level oriented, so it doesn't look at things like the access to care in a specific area, but at the patient level, the clinical care is well captured. And then social and economic factors. These are things like education, employment, and income. The concepts are relatively well represented in SNOMED CT, but again, the data is rarely populated in the EHR. And then finally, we have the physical environment, which is probably where SNOMED CT has the least amount of actual data. And these include things such as housing, air quality, et cetera. So if we look at this holistically, this is, the area where we think there's some work to be done in the standards community. Our solution, after looking at the available coding and pulling the data in from our EHR, we found a lot of codes. We found very low data density. So our solution was to look at how we can incorporate more data at the community level, the community observable level, rather than looking at just patient level assessments. And so what does this look like in practice? We'll go past that. So this is the US core data for interoperability, again, version 4. Just as a reference, I've highlighted here anything that's related to SDOH data. So it's a priority with the minimum data reporting, but again, all of this is at the patient level rather than at the community level. So when we reached out to our colleagues in the sociology, demography, and epidemiology communities, we found a wealth of information out there. We found in the US, the census curates the American Community Survey, which contains very granular data on very small population areas. And then we found numerous derived data sets from that. We also found environmental factors that were of interest, such as the air quality index or the food environmental atlas. And we thought that these could help round out the available data representation that we have on our patients. So what does a community observable look like? We see here a community fact about a patient's rural dwelling status. It is from the Rural Urban Commuting Area Code, which we then see several facts about that, that model traditional SNOMED CT modeling. There is a departure here in that we're adding facts at the community level. So this does not represent patient level data. It represents data about the community that they reside in. So we have geocoded our patient population and standardized data at the community level to help round out some of the available information. And the advantages of doing this are numerous. I touched on them earlier. I think importantly, it promotes precision and contextual appropriateness. There's a ton of data out there. Demographers and sociologists don't seem to be very concerned about metadata management. So that is a kind of a void in that. If anybody's ever tried to navigate the ACS in the US, it is very challenging. It also supports interoperability so that you can share how these are standardized across different research projects. And then just in general, it supports better accessibility to these data sets. So just quickly, this is how we've set this up in our research data mart. We have our general observations at the clinical level and observations at the general level at the patient reported level. We've added an additional fact that has an additional table that has observations at the community level. And then very quickly to kind of get into what level of granularity we have when looking at facts about a community. If we think about where we are right now, we're in the state of Georgia. Within Georgia, there are 159 counties. These range in population from 1,600 to a little over 1 million. The red dot is where we are right now. This is the convention center in Fulton County, Georgia, which has a population of a little over 1 million people. It is the seat to Atlanta, about 14. And within that county, there are census tracts. This is what we have coded our community level data at. Fulton County has 204 census tracts that range from about 2,500 to 8,000 people. And so this is us, census tract for Fulton County. This is the building we're in right now. It represents about 2,000 people and about 0.6 square miles. So why is it important to get this level of granularity? If we look at a fact about the race ethnicity breakdown at the different geographic levels, all within in blue Georgia, in reddish Fulton County, and then in gray where we are right now, we see that we are in a primarily white non-Hispanic area that is not necessarily reflective of the whole of Fulton County. Same with Black or African American distribution. If we go to other community facts, educational attainment, we see similarly towards the bottom that this affluent area in Census Tract 4 has a lot more highly educated people. And then finally, we see the cost of living significantly higher in this area. So if you were to look at community facts at the county level versus at the census tract level, you get a pretty wide distinguishment from those levels of granularity. And again, these are set up by the US Census to measure these kinds of facts. So they are relatively consistent, homogeneous geographical units at the census tract level. And so now our use cases and why we think this is important. We've set this up so that it can be run against an ECL script at our local SNOMED CT extension at the Nebraska Lexicon. So we see here if we wanted to query race using ECL at the community level, we could do so using standard ECL terminology. This is a subset of the codes that are returned that we've structured from the ACS. So we get facts about patient who report being a certain race in a given community where a patient resides. Again, this is how that data is structured. So you can query any of this metadata and set it up just like you would any standard ECL query. This is probably not the best use case for this data, but I wanted to demonstrate a case where you wouldn't want to use that. We have great reporting for race for the most part, and it's more appropriately used at the patient level. Another example that I think represents this much better is education level. So again, you can set up an ECL query to look at education level at the community where the patient resides, and this can be facts about the number of patients or the percentage of patients in a given census tract where they've completed a high school education, associate's degree, et cetera. And you can query this at any level of granularity you want based on the metadata. And this could be what a sample ECL query would look like. So we're querying the community where the patient resides, and we're looking at an attribute that characterizes education and schooling activity processes. So this is where we've added to the editorial process in our extension, and where we think that there's potential for SNOMED CT to fill in some gaps in data availability. And I think this is an important demonstration of why this is important. There are a lot of facts about education that are represented in the SNOMED CT concepts model, not a lot of data. So when we went through and pulled all of the available data, we found that it was poorly reported. And some of these we hope will be increased with the continued incentivization of the Z codes by CMS, but we'll see if that happens. So we had less than 1% of our patient cohort that had data available on community level education facts. This differs from our community level data, which we can query based on the amount of geocoded data we have available, and it stays consistent between these different facts. So we feel this adds quite a bit to the research community. And then the last example would be something similar with housing. Again, housing is not that well represented in SNOMED CT in general. Things like environmental variables, this is something that is just largely missing. So if we wanted to look at a fact that represents the number of units built before 1970 in a given community where a patient resides, this would be what the fact would look like. So we have built out various properties to model that. And if you want to query that, again, you can do that using ECL. And again, this is the distribution. We had a fair amount of discord between the amount of data available, less than 1% available on this community fact as well. And we think this adds to the overall picture. So in conclusion, this is a little bit earlier version of the slide, but yeah, we think that adding additional facts at the community level can help round out the available data for research and for even clinical care. This this deployment opens up any use cases that we think are well a departure from the editorial process right now. We think it enhances SNOMED CT in the long term. And we believe that the SNOMED CT editorial process should be expanded to include observables at the community level. And we think this is just the start. So with that, I will open up to questions.
Okay, thank you, Jerrod. Now we will take questions for Jerrod. And as a reminder, if you're in the room, please use the microphone to ask your questions. Well, we have one here. Jerrod, is there broad utility for developing metadata standards for SDOH elements that are at the community rather than individual level?
Yes, yeah. I mean, I think that the rationale for generating these is similar to the rationale for generating any standards. It just makes things more comprehensive. For the end user, even people doing population level research, there's not a lot of standards development for most of this. So I think that this has broad use for people even doing, data outside of the clinical research community.
Thank you, Jerrod. And we have another one. Any other question in the room? Please, Peter.
Hello, Peter Williams, SNOMED International. That was a really great presentation, and just really struck me how different these concepts are from what we already have in the international edition, where our focus is on the patient. That's the context which is almost assumed into every concept. So adding these is completely different. Did you try classifying them? And if so, was there any interaction between that and the existing SNOMED content?
There is some interaction. I don't know if I can go back. I have too many here, but yeah, a lot of these, there's overlap between the metadata standards. It's still very much open to interpretation at this point. This is a starting point for how we structured the data, but yeah, there is interaction with the existing data.
Thank you.
Thanks.
See, go ahead.
Yeah, I would also like to thank you very much for this great extension of what I thought would ever be possible. Not that I didn't have the fantasy for it, but I never thought that anyone would go as far as you've gone. I appreciate this very much. I think it's very inspiring for all of us who works in all kinds of domains, because it's a mechanism for, but I also have some challenges, and I would like, I don't require an answer, but just a reflection over the following. Do you think that this model could even be extended to include concepts for classifications of disorders and findings? And in my mind, I have ICD-10. So do you think that we could use this model to create concepts that would also represent classes in ICD?
I think it's possible. That's beyond my ability to wrap my head around it right now. It might be something Jim Campbell in the room right now is the main architect for this ontologizing. He might be
have
somebody.
his answer then.
Yeah.
You have a use case that you want to share with us all?
Yeah, sure. I would like to, as we have seen LOINC being included, I would like to see ICD-10 being included, ICD-11 maybe. And rather than having those as maps, I would like to see these as concepts in an extension. And I think this model that you've just presented is giving you all the tools that you need to do exactly that. So that is an implication that's the inspiration that I get.
Yeah, I would recommend looking at our any lexicon site. We do have
You've done it already. Okay.
Yeah.
Okay.
The direct mapping from ICD to SNOMED is a little. It's not always perfect. Yeah.
Okay. Yeah, but again, thank you very much. And
We'll send out the URL in the chat.
Yeah, it's it's at the bottom.
Another question?
Okay. There you go.
Yes, thank you.
Go ahead, thank you.
Yeah, thanks for a great presentation and that model. I had never thought of it before. It seems very logical. My reaction, and maybe this is sort of a next step, is potential duplication of things that are done in public health, I guess, outside of clinical settings where they're looking at all the census tracts and these constructing different indexes. I've seen the social vulnerability index and that kind of thing. So I wonder if you've had a chance to talk with public health people or thought about how this would, what the value of this data within an EHR versus maybe a population health record or community health record or those kinds of use cases. I don't know if you have any thoughts about that or sort of moving this forward in a way that it's not duplicating stuff that a lot of people might be doing in different places.
Yeah, absolutely. And that's a very important point. We don't claim to have identified even the tip of the iceberg with regard to the types of data that could be modeled this way. But it's not something that community is thinking about applying at this level of granularity. And largely, like I had briefly mentioned, they don't do metadata standards development. So it's an area that I think that community could benefit from, but we had approached our public health colleagues, our sociology colleagues, and our demographers that we knew, and they pointed us to these data sets as a starting point. Yeah.
And I would just elaborate, thinking of the slide that Jerrod shared, the US CDI points to, problem data, interventions data, assessments data, treatment data. All of those are potentially relevant to the researcher in equity, okay? We have spent a fair amount of time curating the assessments data, and that's why Jerrod is discussing our extension of the observables model. We've also done some computable phenotype development, for example, from the diagnostic data. Okay, that's another domain, if you will, pertinent to social determinants that, you know, we didn't discuss today.
Thank you, Jim. Thank you, everyone. And with that, we will conclude this session. Thank you, Jerrod. Online delegates can join another session through the event lobby. Thank you all.